Tetralogy of Fallot, and there's a couple things to what happened here, and because of that, the USMLE likes to go after this congenital abnormality more than any of the other congenital abnormalities, and also not only that, but also because it's the most common cause of cyanosis in early childhood. So that's one of the other reasons they like to go after this. So what exactly happens in Tetralogy of Fallot? So basically there's this anterior superior displacement of the infundibular septum. So that's sort of the embryology behind this. And again, just like that, they can ask you the question. They could tell you the patient has Tetralogy of Fallot or hint it to you, and they can ask you which of the following embryologic defects most likely contributed to this. And the answer would be this displacement of the infundibular septum, right? So they can ask it just like that. All right, so let's talk a little bit about what happens in Tetralogy of Fallot. So pulmonic stenosis is obviously, going to be the most important determinant for prognosis, and they love going after that point also. So they tell you that there's pulmonic stenosis. That's one of the things that this causes, one of the four things that make up tetralogy, right? Tetralogy is four things that make up Tetralogy of Fallot. But pulmonary stenosis, pulmonic stenosis, is the most important prognostic factor, inversely related. So they literally will ask you which of the following defects would predict prognosis, something like this, and the answer would be pulmonic stenosis. They love that point. So please, just understand and recognize that out of all the four parts of Tetralogy of Fallot, pulmonic stenosis actually determines or predicts how the patient does, and which we call medicine prognosis, if you can sort of predict how somebody will do with the condition. Okay. So aside from pulmonary stenosis, you see a VSD, right? There's going to be a VSD, ventricular septal defect. There's also going to be an overriding aorta. So you can see the aorta sort of overrides. You can see in this image here clearly, one is going to be your VSD, two is going to be your right ventricular hypertrophy. And again, the right ventricular hypertrophy is going to look boot-shaped on chest X-ray, but we'll get to the chest X-ray. But just looking at this gross anatomic image, so you have one is your VSD, two is your right ventricular hypertrophy, three is your overriding aorta, and four is going to be your pulmonary stenosis. So you can see you're going to have the right ventricular hypertrophy, VSD, overriding aorta, and pulmonic stenosis. So now if you actually look at the chest X-ray, the heart, which isn't a circle, but it's definitely not normally boot-shaped, and here it looks almost like a boot. And when you see this, it's pathognomonic. And when we see pathognomonic, we mean really you can almost diagnose it based on that. On chest X-ray, the right ventricular hypertrophy in Tetralogy of Fallot looks boot-shaped on heart X-ray, chest X-ray. So just a little bit more about the pathophysiology. So the pulmonary stenosis is going to force the flow to the left. So right to left flow across the VSD, and that's obviously going to lead to your right ventricular hypertrophy, and obviously going to have a very hypertrophic right ventricle, which will cause the boot-shaped heart. One thing that they like to give in buzzword is a TET spell. They could either give it to you straight up as a buzzword, but usually they would describe it as like the baby is crying, or like there's a fever or exercise is worsening. All these things worsen right ventricular outflow obstruction, and therefore the baby's going to come into this is going to turn like blue when they start crying or something, because it's going to worsen the right ventricular outflow. It's going to obstruct it. So when the baby exercises or screams, it's going to have a TET spell, or obstruction of the right ventricle. One thing to note is that this is associated with the 22q11 syndrome genetically. So they sometimes could just kind of give you a picture, a clinical scenario where there's pulmonic stenosis, overriding aorta, VSD, and right ventricular hypertrophy, and they can ask you which of the following, genetic makeups is associated with this, and obviously the answer will be the 22q11 syndrome. And that's something that they do like to test, because genetics, when it ties into clinical pathology and clinical medicine, they like to test that as well. So more on the pathophysiology, because sometimes the question doesn't give it to you so clear. They just kind of give you a hint based on the shunting. So they would tell you that when the patient squats, right, there's an improvement in cyanosis. So I just want to run you through the pathophysiology of that. So understand, like, when you're squatting, like, what exactly are you doing, right? Essentially, your systemic vascular resistance, or the resistance in your systemic vessels, is going to increase greatly. So when you have increased systemic vascular resistance, it's going to decrease this shunting, this right-to-left shunting. Ultimately, it's going to improve your cyanosis. So that's sort of why squatting improves the cyanosis. And that connection on a pathophysiologic level, is relatively important, because they will sometimes, want to go after that. Okay.